Next out is a colleague of mine and also another talented PhD student of our center, Kristiansen. Eli has been with our center for many years, and earlier you worked as a senior advisor. Now you're currently in the last phase of your PhD, and today we'll hear a study which is included in your PhD. So if you have questions for Eli, please ask in the Q&A. Eli, the floor is yours.
Thank you. Well, as Eirin said, I have worked with eHealth for many years, and I am now finishing my PhD degree within eHealth, and I'm studying in particular the access to the GP when e-consultations are implemented. But today I ask if user experience can give us any insights of non-use. And to illustrate my points, I will use a study I have done of older users' experience of access to and use of e-consultations with the general practitioner. But first of all, what is digital divide? Digital divide is a term that refers to the gap between the ones that have access to technology and the ones that don't, or have restricted access to, or don't use the technology, the non-users. So when we talk about digital divide in healthcare, we talk about the people that's on the one side of the gap. And these people are often the marginalized groups. That can be patients that are struggling with addiction. It can be homeless patients, people living in rural locations, or older patients. And in my study, we focused on the older patients, and we did that for several reasons. It has been shown in earlier studies that the older patients can have problems to utilize digital services, and this can affect their access to healthcare services. And at the same time, we know that older patients are the ones that often have the highest need for healthcare services and may therefore be the ones that could have the most to gain by using digital services, by eliminating travel time, and also the possibility to use technology to self-manage their health conditions. So why is it important that we focus on digital divide when we research healthcare technology and e-health? Well, in the Norwegian healthcare system, we have a fundamental value, and it says that we should minimize inequities in access to healthcare. And one of the core values of the Nordic general practice states that patients with the greatest need for healthcare should be prioritized. So how are these core values affected when we introduce digital services and digital access? It is important to ask if technology and digital access give the same possibility to access for all patient groups. But studying non-use can be quite challenging. And in the study of e-consultations with the general practitioners, we started out by conducting numerous interviews with individuals who were not utilizing the service. And our aim was to investigate the consequences of non-use and the underlying reasons for non-use. But we encountered difficulties in extracting valuable insights from this material. And there are probably many factors for this challenge, but one significant issue that we observed was how it's difficult for non-users to engage in meaningful reflections about non-use. In many of the instances, the non-users were not even aware of the existence of the service they were not utilizing. And so to ask them to reflect upon consequences of not using a service that they didn't even use, it proved to be a very daunting task. So to address this problem, we adopted an alternative approach where we studied the experience of the actual users who accessed and utilized the service. And then our objective was to gain insights into the ease of accessing and to using the service. And we aim to translate this knowledge into understanding the challenges associated with the service. And this approach also allowed us to generate insights on how to modify the service to make it more user-friendly for the non-users who might consider using it in the future. And to gain insights into the non-use, we chose to use a framework that is developed by Levesque in 2013. This framework offers several advantages, although it may appear somewhat complex at first glance. It was originally designed to analyze patient access to healthcare and not specifically digital services. Nonetheless, it proves to be highly adaptable for services within digital access. And in this framework, access is defined as the opportunity for individuals to reach and obtain appropriate healthcare services when they perceive a need for healthcare. And the framework describes this concept through a series of steps represented by the blue boxes you see in the middle of the figure. But furthermore, this framework evaluates access to healthcare services from both the supply and the demand perspective. On the supply side, the white boxes on the top of the figure, the framework outlines the characteristics that the healthcare offerings should possess to facilitate patient access. And these supply characteristics are that the offer should be approachable, it should be acceptable, available, affordable, and appropriate. And then we have the demand side of the framework. And these are the boxes in the bottom of the figure. And the demand side identifies the abilities that the patient must possess to be able to utilize the provided service. And these patients' abilities, when combined with the supply characteristics, define the overall accessibility of the healthcare service. And in our study, we particularly focused on the framework's emphasis on the patient's abilities. And these are the ability to perceive, the ability to seek, the ability to reach, to pay, and to engage. And the reason why we selected this framework of access is because it looks at access as more than just the supply of a service. And it incorporates these both two dimensions, both of the supply and the patient abilities. And we really liked this double dimension that it had. And as Erin said, I have brought a study today. This study is done in the primary healthcare in Norway. And in particular, we have studied e-consultations with the general practitioner. E-consultations are a written service and an asynchronized service that is used by patients to send a text-based clinical inquiry to the GP through an online patient portal. In Norway, offering e-consultations is recommended by the health authorities, but it's not mandatory. And today, around 50% of the Norwegian GPs offer the service. The primary healthcare system in Norway is built around a GP scheme, meaning that all Norwegian citizens have the right to choose a regular GP. And the GP is the first meeting we have with the healthcare sector. And the GP is also the gatekeeper for hospital services and for sick leaves. The patients have a small out-of-pocket fee for consultations, and this fee is the same whether the patient chooses to do a consultation face-to-face or an e-consultation. And I also wanted to show you why we think it's important to look at this particular service, why we need to produce knowledge about the access of and use of e-consultations. This graph shows the use of e-consultations before, during, and after COVID-19. The use of e-consultations with the GP was at around 3% before COVID-19 came to Norway in March 2020. In connection to the lockdown of Norway, where many GP offices closed down for face-to-face patient contact, the use increased significantly. And after the pandemic, we see that the number have stabilized at around 25% of all consultations. And I just want to pause a small minute with that number. Actually, 1 out of 4 of all Norwegian consultations with the GP is an e-consultation. And this is a really high number, so we see why it's important that we do research on this service. However, what we also see is that the oldest patients have an overall lower use of e-consultation than the other age groups. So we wanted to explore older patients' experience with accessing and using text-based e-consultations, and we also aimed to translate these findings into knowledge that could help non-users. So we performed in-depth interviews with older users and analyzed the findings in light of the LEVESQ framework. We identified 4 main themes that described the older patients' use of and access to e-consultations. First of all, The respondents highlighted the importance of having enough digital health literacy to learn about the service and to be able to use e-consultations. None of the respondents I talked to had received information about or been encouraged to use e-consultations by their GP. They had all adopted the service by themselves. And they worried that a possible decline in their own health literacy in the future, for example, the possible manifestation of health issues that often come with older age, like lower vision, hearing loss, trembling hands, cognitive impairment, they feared that this could possibly affect their ability to use and keep up with the digital healthcare service in the future. This respondent, she was 69 years old, and she said to me, I want to continue to use text-based e-consultations as long as I'm capable to. I can see how there can be challenges if I get dementia or poor eyesight, for example. The second theme revolves around e-consultations being considered a convenient option. The respondents explained that it was easier to contact the GP through e-consultations compared to physical consultations because the service did not depend on the GP's opening hours or the GP's availability. However, it's important to see this theme in connection with the next theme, the importance of voluntary use. E-consultations played an important role in giving patients the possibility of being actively involved in managing their health, and it was perceived as useful when the patients felt in control of deciding when to use it and if they wanted this extra self-managing role. The respondents argued that everyone should be allowed to see the doctor in person if they want to, and no one should be forced to do an e-consultation, even if the doctor thought it was enough to clarify the problem. Overall, face-to-face consultations were considered by my respondents as safer than an e-consultation for severe issues. Let me read you this short citation from a woman. She was 67 years old, and she said, "The GP contacted me in writing, but I thought I should meet him. I thought it would be good to talk to him about certain things, and we could discuss what he thinks and means, and eventually we could agree." The last theme we have called the importance of a trusting relationship with the GP. The older patients wanted to use e-consultations with the GP that they already knew from before. The patients thought it was easier for them to describe their health problem in a text, and also for the GP to capture the situation and the importance of the situation if there was already a relationship between them and they knew each other. Furthermore, the patients seemed to have less concerns of misunderstandings and more trust in the outcome of the e-consultation if it was sent to a GP that they knew from before. I'm going to read you this citation as well. It's from a male. He was 69 years old, and he said, "I feel reassured about using text e-consultations because the GP knows me so well. But then again, I have tremendous trust in the doctor's office and the doctor. So maybe because of that, I trust what she says without having to sit physically in the office with her." So, how can we apply this knowledge to assist the non-users? To address these questions, I'm referring back to the Levesque framework of healthcare access. And as I explained before, it has these several key dimensions. But let's focus on the patient abilities. First, there's the patient ability to perceive. And this means the ability to be aware of the existence of a particular service. Our research indicated that older patients tended to become aware of e-consultation by chance. Often they stumbled upon the service while exploring in the digital portal. And this way of discovering a service requires a certain level of digital health literacy. Notably, GPs and GP offices didn't actively provide information about the opportunity to use e-consultations, and therefore we believe that offering clear and accessible information about the service could greatly enhance patients' ability to perceive that there is an e-consultation service. Secondly, the ability to seek healthcare services involves the patient feeling safe and unburdened by social or cultural barriers when accessing care. And I think there are two key aspects that are important here. First of all, we need to provide patients not only with information about the existence of a service, but also what the patient is to expect when using the service and how the service actually works. And this can give a sense of security, and it can encourage non-users to seek the service. And secondly, it's crucial to maintain easy access to traditional in-person consultation options alongside e-consultations. Digital services should always be presented as a voluntary complement to, rather than a replacement for, physical consultations. And this approach can ensure or help the patient's willingness to seek the service. Next, let's consider the patient's ability to reach the GP through e-consultations. This hinges on their capacity to access the service. And we observed that the service availability played a significant role in this regard. Respondents of our study highlighted the importance of e-consultations being accessible day and night and 7 days a week. And this lowered the threshold for them to seek, to reach out for help. So we recommend to maintain predictable and consistent service availability to facilitate the patient's ability to reach out. In Norway, patients with high healthcare need receive an exemption card. An exemption card means that they get free healthcare services for the rest of the years. And this was the case among many of the respondents in my study. And this might have influenced their perception of the affordability of e-consultations, because none of them were concerned or raised any concern about the ability to pay for the service. So consequently, we argue that for the provision of we argue that the exemption cards needs to continue to be offered, and this will help ensure patients that they can afford the service. Lastly, the ability to engage. It evolves around trusting and believing the outcomes of the e-consultations. And patients who had a trusting relationship with their GP perceived the results of the e-consultations as appropriate and safe. And therefore, maintaining the GP scheme is a recommendation to make the service more appealing and trustworthy for the non-users. Okay, so in conclusion, how can we facilitate use and prevent the involuntary non-use? First of all, information is key. Second, the voluntary use of digital service. Digital services should always be presented as a voluntary choice and never forced upon users. Third, establishing and maintaining trusting relationships between patients and healthcare providers can greatly assist non-users in overcoming barriers to digital services. And finally, I think it's crucial to recognize that digital capacity is not the constant. Users may become non-users for various reasons, such as new diagnoses or age-related healthcare issues. And therefore, we need to have this in mind when we plan and develop for digital services.